This next few minutes, we'll talk about a case in non-metastatic CRPC, and like the last section, I hope to make this as interactive as possible. These topics were well chosen for controversy, so moving on. So I've got a few questions specific to the panel at the end, but mainly I want to spark some questions as we go through this. So, one of the nice things that happened in my practice this past year is I hired what we call a decision support analyst. That's a fancy term. And what we did is we found a GM mechanical engineer, process engineer to come into the practice and be our process engineer and sort of open all of our data to us. And I think in a private practice that's been a long time coming, and it's really been a big benefit to us. So when we came up with something like this, I was able to go to him and say, who's the best patient that would give us the most discussion? And he pops this patient out for me. So anyway, we got a 70-year-old fella who's had prostate cancer diagnosed for 10 years. And when it was diagnosed, he was a 4+3. His PSA was 8. He had a negative DRE. Imaging at the time was negative, and he had radiation therapy 10 years ago. He's also an avid golfer and a gardener, and he was asymptomatic. So moving forward over the next several years, his PSA kinetics are shown here. The time frame between each one is, the first one was 3 years in, and the next two were 6 months apart. So you got a guy who's now 7 years out from IMRT, and his PSA, while still low, has shown some evidence of increasing. Dr. Klotz, would you do anything at this point? He is asymptomatic still.
No.
Anybody in the panel?
I mean, he still has a prostate.
Correct.
So he had IMRT, period. So, this to me, so far so good.
Yep. Anybody do differently?
He's how old now?
He is 76.
Okay, so, even if he has a recurrence, he's probably not going to die from it, and I wouldn't be worried about him at all at this point.
So I agree. Unfortunately, difference of opinion, the patient and his primary urologist decided to proceed with a biopsy, at which point they demonstrated recurrent cancer or untreated cancer in his prostate, and he had cryotherapy with the intent to cure. Post-cryotherapy, his PSA went down to 0.09, and 6 months later, it's about the same. But about a year later, there seemed to be an increase. And at that point, he had imaging done and had nothing on imaging, including in his prostate bed, or his prostate itself. So he's initiated at that point on Abiraterone and ADT, and for 6 months his PSA was undetectable, but then, and this is where things start to get a little interesting, PSA goes up to 23. Right, and we've all seen these cases like this that just don't make sense. What happened? Did the planets all align? Was the moon in the seventh house? Or what happened here? But it is what it is. So his PSA was up 23. This was repeated. It was verified. His testosterone is castrate. It was 18. But his PSA doubling time also is remarkably just a switch flipped. So, Dr. Cookson, you have any comments at this point?
Well, he's a real outlier. I mean, we're in trouble. You've hit him with combination therapy long before any of us would have even considered it, and it only lasted 6 months. So I'm really worried that, the androgen axis therapies are not going to be effective in this gentleman. He needs to be restaged and see where we're at, but he's in a lot of trouble given this explosion in his disease process.
Yeah, and certainly in your practice in Oklahoma, you see some similar people sent to you from outside institutions at this point, right?
We do see outliers, absolutely.
Yeah, Dr. Klotz?
No, just a comment. He should not have been started on either ADT or particularly Abiraterone for a PSA 0.3. There's the only evidence we have for a threshold for starting ADT in men with biochemical failure, which is all he's got, is basically it's EORTC 30891, the old Studer trial, which was hormones versus nothing. And those thresholds that showed a benefit were somewhere around 20 to 50.
Right.
Like there's just no indication. Now, you have to wonder, in this guy, he's gone 8 years or something, fine, and you start him on hormones and boom, 6 months later he has massive progression. This is some kind of idiosyncratic reaction of his cancer cells to maybe to ABI or ADT, I don't know, but that was not the right thing to do, mainly for the quality of life reasons.
Yeah, totally. Dr. Hirano?
He's already received.
Do you have a comment?
Yeah, so it's very fast, so tumors growing. I suppose some micrometastasis. So I selected chemotherapy, so early docetaxel recommended. Yeah, because he already received the under the ADT plus Abiraterone, right?
Right, yes. So going on the assumption there's micrometastasis,
yeah.
you'd start systemic chemo.
So and immediately treated with chemotherapy is much better.
And Dr. Cookson?
You said his scans are negative. Can we qualify what scans were done?
Yes, he had a Tec-99 CT and an Axeman scan.
Okay.
We have no access to PSMA at this point.
Did he have a pelvic MRI or anything to look for adenopathy?
He did not. He had a CT, which showed no adenopathy.
Okay.
And so as Dr. Klotz pointed out, the first thing that I think would come to anybody's mind, have we triggered something? Did we do something? Is there some idiosyncratic reaction here? And how do you test that hypothesis if you do in a safe way? On the other hand, do you now say, as his primary urologist did at the initiation of Abiraterone, that we're now classifying this guy as micrometastatic nmCRPC? Right, it's a tough question, and I like this case because it highlights, maybe not so dramatically, but very often, almost every day in an advanced prostate cancer clinic, you're faced with a similar question. How do I actually classify this patient? Right, and so, initiation, Dr. Hirano, would you expound a little bit on systemic chemotherapy? I think that's something that not a lot of people would have considered at this point.
Yeah. When in the chemotherapy, just the first times, so we recommend this, to admit in the bed. So we cannot treat this inpatient. First admitted in the floor, in the ward, and treated with the chemotherapy, and watch to how to affect the adverse effect. And next time, so we treat it as an inpatient as chemotherapy.
Okay, so at this point he was rescanned, and his PSA 3 months later is now 50, and he was scanned again. Again, same scans. He had an Axeman, he had a CT. He did not have a Tec-99 bone scan at this point.
He's still on Abiraterone?
He's still on Abiraterone.
I think I would try stopping the Abiraterone. Maybe, who knows?
Yeah, no, and that's the conversation exactly that I had with the patient, because this is a who knows. This doesn't fit the mold at this point. And the other thing that I didn't have in the slide is that in the past 6 months, his testosterone did come up at one point to a 58, and so he was re-challenged with a different LHRH prep, and it came back down to 18, which is normally where it had lived. Not sure if that had anything to do historically. Did entertain the option of an orchidectomy with this gentleman, and it's like Neil pointed out in the prior conversation, orchiectomy is something that I find myself talking to patients a little bit more about the past couple of years than I did the past 20 years. Not all the way back to where we were in the 80s or 90s yet, but as we pay more attention to testosterone, and absolute levels matter, absolutely, the desire to drive this as low as possible, I think, can become sort of a mission all of its own, and I'm not sure what the rest of your experience has been with that. In this fellow's case, we did get him back down. Sometimes, though, as you know, you change preps, you don't get the testosterone back down. You talk orchiectomy. This guy's funny. He's at this point like 77 years old, And like, well, come on, man, what? You're not using those things anyway. What good are they doing you? And he scratches his head, he looks, and he sort of says, well, Doc, I know, but they sure do dress a man up well. And I couldn't argue with that. So, Dr. Klotz?
No, I mean, he will have a positive PSMA scan, almost certainly. So that would, and you know, there might be a way to get one somehow on him, but that would provide some clarification. Like the guy has disease somewhere.
And you're basing that on his PSA being up to 50?
Yes.
Yeah.
Or you could try an FDG PET. Just
Yeah.
regular old PET. There are definitely cases that are even PSMA negative, even with PSAs as high as 50 that are FDG positive. So, and that one's, you know, you can get pretty easily.
Yeah, Rob, can you expound on that a little bit? Because that's something that was totally unknown to me until about a year ago. We brought a hem-onc into our practice and started working with him, and the amount of use and validity he put into FDG PETs on our prostate cancer patients totally astounded me. So can you?
Yeah, we were all taught that, you know, FDG PET was useless in prostate cancer, but Memorial Sloan Kettering has done a lot and published a lot on this, and certainly in the castration-resistant setting, most cases will actually be FDG positive. And then if you look at the PSMA theranostic situation from Australia, they actually selected patients on the basis of PSMA positivity alone because they found in quite a number of patients there were FDG positive areas and PSMA positive areas that did not correspond. So I have a case not quite like this, but PSA rising, should be PSMA positive. PSA I think is 20 right now. He and I are very frustrated. We got an FDG PET and showed disease in his lungs. So just
Excellent.
a thought.
So how often, before you hand the mic back, Rob, how often would you say do you get an FDG PET these days?
Only in patients where PSMA is negative, because I have access to PSMA for many years. So PSMA is negative, or if they're being included in a trial of a lutetium PSMA agent, in that case it's a selection criterion.
Okay, so if they qualify PSMA, you can't get one, you'd go ahead at this point to FDG PET. Dr. Moeller?
Yeah, I just want to remind the audience here that every slide you've shown so far has said asymptomatic, and this is why we need NCCN guidelines. This guy's being treated when he hasn't met ASTRO criteria for failing radiation. Then he's getting androgen deprivation therapy, which there's no good study anywhere that shows when you start it, how you give it, what agent you use or whatever alters survival. We have to remember that. And this is an example of PSA anxiety of the worst degree, which should be a psychiatric diagnosis nowadays. And we all contribute to that by this kind of craziness.
Is that a psychiatric diagnosis for the doctor or for the patient?
I think it is oftentimes both.
Both. Yeah, thank you. And you caught, I mean, I did intentionally include asymptomatic up there because that adds a significant layer to this conversation. And that maybe not every patient is as dramatic, but certainly in many patients we have patients where we have to ask ourselves, what are we doing here? They may be asymptomatic and we're diagnosing progression based on a PSA or maybe just one new lesion and it's asymptomatic. So that was a question I had later on in the deck, but we're here. How would you define progression as far as changing therapies, Dr. Klotz?
Sorry? In this patient?
In general.
Oh, you know, it depends on the state. Like, there's not a short answer to that question.
For an nmCRP patient?
There's the, so in CRPC, there's the St. Gallian consensus described what they call the 2x2, meaning 2 new METs on seen on two successive bone scans in CRPC rather than just PSA.
For non-metastatic?
Well, no, from non-metastatic to metastatic or metastatic to to progression.
To progression.
But I mean, from the non-metastatic to metastatic, I think it's simpler. It's basically new metastases.
So
with rising PSA.
Any one MET, no matter what size, no matter what PSA is?
Well, if the guy goes from no METs to METs, he's had progression. So I'm not being legalistic. I'm just saying, I mean, to me, that's kind of...
And you validate that on a second scan?
If there's some question about it, but otherwise I don't. I mean, if it's uncertain whether it's a metastasis or not, for example, solitary lesion, you know, non-specific, that's a different story.
Right.
That's a quick question. How do you know this guy is not getting exogenous testosterone from some family practitioner?
Well, serum testosterones. Other than that, we don't. If he has some androgen compound that's not being tested in our lab assays.
Because he's on Abiraterone. His T should be 0.
Yeah.
And it's not. So something weird's going on.
Yeah.
Compliance.
Mike, did you have?
Yeah, so a couple things. One, I mean, you've picked a case that has a lot of interesting wrinkles to it, and we're saying, like, I've not had anybody on that combination of Abby plus LH that had a detectable level PSA rising like you described, but this guy is weird. Things you have to start thinking about when you see this, though, are like small cell variants and some, you know, unusual histopathology that is escaping. He probably has variant that you might test him for ARV7. He should undergo germline testing because you're thinking ahead. I agree with everybody right now that the treatments he rendered were way before I would have done it, and they aren't guideline-based. But I'm assuming something's going to blossom here, so be thinking ahead. You know, maybe you'll find, you know, microsatellite instability. Maybe you'll find a BRCA mutation. So I would be already planting seeds while we're watching him.
But
Yeah,
this
good
is not
point.
really the neuroendocrine small cell scenario because he's got no Mets that are.
No, I'm afraid he's going to
And he's
blossom.
got a high PSA.
Yes,
So-
but I've seen that. We've given patients with locally advanced prostate cancer conventional strong therapy, and they blew right through it. They don't have to make no PSA to be
Right.
neuroendocrine.
Right.
Right, and he did have ARV7, which was negative, and he also had a hereditary risk panel, a my risk panel, which was negative. So no BRCAs. Yeah, Dr. Shore?
So I have a question to Jim. I want to make sure and then I have a comment about PSA rise when someone gets started on an FDA-approved nmCRPC therapy, of which there are 3. So first question to you, Jim, is I just want to be clear here. You were focusing on this challenge about him being asymptomatic, which is true for all of the nmCRPC trials. The patients were theoretically asymptomatic if you exclude the fact that being on ADT for a period of time doesn't cause symptomatology, which I'm obviously saying that rhetorically because it clearly does. But in the Spartan, Prosper, and Aramis trials, the patients from a performance status were mostly ECOG 0, minimal numbers of 1s, and they're essentially asymptomatic. So these drugs were all approved on the basis of being asymptomatic. So in this particular case, when he developed that 23 and had the PSA doubling time, I think it was 6 months or 3 months.
3 months.
You're not disagreeing that he shouldn't be on Abby or an approved therapy at this time?
I'm only challenging when he was cryoed and when he was put on those agents.
Yeah.
To right now, for metastatic CRPC in an asymptomatic patient, it is reasonable for the purpose of delaying the development of metastatic disease. Remember, no trial yet shows a change in survival, and I will predict to this audience that there will not be one. But the NCCN panel had a heated discussion because we have never yet put something in the guideline without a change in overall survival.
Okay.
But it is definitely important to delay the onset of metastatic disease for quality of life. And that's why all of these entered the guideline, and it's why they were FDA approved. That is of great value for these 3 agents. Having said that, they are extremely expensive. And what will be interesting is when we get PSMA-PET widely used in the US like it is in almost the whole rest of the world, we're going to find out that there aren't so many of these nmCRPCs. They're going to all convert over. We'll have the Will Rogers effect, and these will all become metastatic CRPC. So this is a changing landscape, and we all got to be very interested in following it carefully.
Can I respond to his? I completely disagree with you in terms of your wager about the OS. So we'll talk about that later. So now let me ask you this. assume that the OS data, which is premature for all three of these drugs, let's assume in 2020 that we will see final analyses on these three drugs in 2020. Let's assume OS is met. Does that change your thought process here?
No, because they're already approved.
Does it change your thought process in terms of the value of starting the patients on despite the cost?
Oh, does this prove that earlier ADT is
Yes.
better than later ADT? No,
Well,
that
not
that
earlier
requires a
ADT,
study.
later ADT, but just starting the patients on an nmCRPC therapy regardless of the cost. If there's OS benefit now.
Well, what you're saying is way too simple a statement, and I'm never going to agree to something that simple.
Well, I'm sort of just responding to your negativity about the OS, which I disagree with. So I think it's really important.
Well, I'm only quoting the last 6 decades of clinical trials in the androgen deprivation therapy space.
Okay.
If you want to overcome 6 decades of data with these last 3 trials, so be it.
Okay.
But I don't.
Jim,
I'm glad we're recording, so we have to make our wager afterwards.
Wait, don't stop now, Neil. This is good.
No, this is good. And so,
I never wager more than $1, so you're in trouble.
but Jim,
dollar works.
Jim, I just want to challenge you with the IceCap collaboration that Chris Sweeney led. Basically showed that metastasis-free survival is a surrogate for overall survival in CRPC.
Correct.
So why are you so skeptical that there's going to be a survival benefit?
I just want to see the overall survival data. I'm the eternal skeptic.
We've got that.
Yeah.
All right, we have a dollar wager. All right, so my other comment, and thanks for giving me the time, Jonathan, is of course in the 3 trials, patients and the sites were technically blinded. Of course, we know a lot of folks were checking PSA anyway, but they were all theoretically blinded. And so people were not unblinded based upon a PSA rise. They were ultimately unblinded based upon rigorous monitoring of their conventional imaging, CT scan and technetium bone scan. We actually have a paper coming out, Fred Saad's first author, looking at the conversion of imaging positivity. And once you get these great PFS data on all 3 trials, it's like 0.06, 0.07. The PSAs plummet. But when you start to see a little bit of rise, an uptick in that PSA, as opposed to what we usually see, we see a much more significant, higher percentage of imaging conversion. So I think it's a really good paper that we have coming out on the PROSPER data that will show that.
Good. Thanks, Neil, for the input. And one last point before moving to the next slide is that whether we're at an academic center or a larger local group where we function as a referral center, I think, yeah, this guy is a bit of a wacky case, but we all see patients referred in that have twist. And unfortunately, a lot of the twist is oftentimes not the disease itself, but how they were treated. Right, and so the reality is how you manage things, the pitches that are thrown your way is part of what we're trying to answer here. So this guy, when I looked for this patient a month ago, I was like, you can't make these things up. You're talking about how wacky this patient is. I said, I literally could not have made up a more bizarre scenario than what I have been given here. So I was able to update the slides week before last when he came in for an appointment, and his PSA was up to 153. All right. He was imaged again the 3rd 3-month time in a row with the Axeman and CT, and imaging is still completely negative, and he is still completely asymptomatic, so he is still completely nmCRPC. All right. So at this point, would anybody, other than I still like Dr. Klotz's suggestion potentially withdrawing the Abiraterone, would anybody do anything different to this patient at this point? Or chemotherapy, as Dr. Hirano said?
Yeah.
Well, we have no data on chemo for patients with non-metastatic disease.
No, I agree.
And it's toxic, so I think that would be the wrong thing to do.
Yeah. I have I experienced so a couple of patients, so such a patient like this patient, and they're using the chemotherapy, but still PSA go down, and still about 1.5 year, so still keep the low levels, the PSA.
And is there need to do anything?
Yeah.
I've had some kind of a similar patient, and doing a rectal exam, which is real simple, because this is a clonal disease. And I had a patient who had negative, I think we had negative Acumen or whatever, and I realized I hadn't done a rectal exam for a while, and he had a single nodule that was biopsy positive. So you never know, and you got to be a careful, clinician all the time.
Go back to Urology 101, I guess, huh? All right. I'm sorry, you have a question back here?
Quick question. Do you, I had the same thought about the rectal exam, but also do you have an alk-phos on them? And there is data in the rise of PSA post-prostatectomy. You give a bone agent like strontium, but now we have radium-223. Any thought of just throwing that on there and seeing what happens?
Yeah, we did throw alk-phos into our panel actually this past year, and so these patients have it routinely. His is still normal. So just wrapping up non-metastatic CRPC for the panel is, you've got 3 approved options. How do you choose one? Is it dealer's choice? Do you feel the patient out and think, okay, this one's better for this guy? Or do you have some routine? Dr. Klotz?
I think it's dealer's choice. Darolutamide looks a little less toxic and maybe a little less efficacious. So it might be a better drug for frail patients, but it's, Enza versus APA otherwise. And probably Abiraterone, not in this setting, but just because the study hasn't been done, probably works as well, although we don't know that for sure. And I nowadays am using APA just because I want to get some experience with the drug, and I got plenty of experience with Enza, so I would probably put them on. I would stop the Abiraterone, kind of look for a Abiraterone withdrawal effect,
Right.
and then probably switch him to APA.
Anybody on the panel do differently?
Yeah, me? Maybe so. Yes, switch. Yeah, I agree with the switch is Abiraterone to or enzalutamide or apalutamide, because we can use enzalutamide for non-metastatic CRPC.
Right.
Yeah, but here is no. In the United States, you cannot use the enzalutamide, right?
Yes, we can.
Yeah, you can't. Yeah, we can. We can use enzalutamide.
Any final comment on your choice of your first ARI, Dr. Cookson?
I like the idea of stopping the Abby and 3 months later, let's see where we're at, and then adding one of the 3 drugs. And there is some data for that in the metastatic state and the CARDS studies and things, but I expect to get a short run of benefit because none of the 3 agents that were approved were kind of Abiraterone prior treated patients.
Perfect. Well, one last question, then I'm out of time. I don't want the poopah mad at me.
Hey, Jonathan, it's Tracy. I just have a quick question, and it's really to Jim's comment about survival, which I think is fair, right? Everyone wants to see overall survival in the final analysis. So my question is, if when we show the final analysis, which the FDA requires, and one of the drugs actually hits OS and the others don't, or 2 hit and 1 doesn't, will you all still think they're all the same, or will there be a difference at that point?
That's a
Nice
winner.
Depends
Well,
on the
thank you much for your
data.
participation.
Fair question.
We'd probably have a hell of an argument about it.
Could be a winner-winner chicken dinner.